Welcome to our lecture on zoonotic diseases. The focus of today's lecture is Lyme disease. The following presentation is brought to you by
Sydney, Sam,
and Mike. We hope you enjoy the show.
What is zoonotic disease? First, what is a zoonotic disease? Any infectious disease that can be transmitted between species is called a zoonotic disease. This means that infectious agents can be transmitted or shared between species, such as dogs and humans. Those at risk are any humans in contact with an infected animal or a disease vector. Vectors are carriers of a disease that spreads from infected animals to an uninfected animal or human. In one study, researchers found that 1,415 pathogens are known to affect humans and 61% were zoonotic. An example of a zoonotic disease that this presentation will focus on is Lyme disease. History. First diagnosed in children in Lyme, Connecticut in 1975, Lyme disease was initially misdiagnosed as juvenile rheumatoid arthritis. However, the Lyme locals realized that most affected children lived near wooded areas or other locations liable to harboring ticks. They also began to notice that symptoms would first present themselves in the summer months, which coincides with the height of tick season. In 1978, Alan Steer officially realized Lyme disease is a tick-borne disease. Later in 1981, Willy Bergdorfer discovered B. burgdorferi and identified it as the bacteria causing Lyme disease by reaction with immune serum from Lyme disease patients. Lyme disease has now been diagnosed in all 48 states in the continental U.S. and is the most common tick-borne disease in North America and Europe. Between 2003 and 2007, the Centers for Disease Control and Prevention reported approximately 111,826 cases in the U.S. alone. The threat of Lyme disease and other zoonotic diseases is only growing. This increasing threat is due to increasing global movement of people and animals and the effects of human populations expanding into previously undeveloped or uninhabited wildlife habitats.
Prevalence. In the U.S., Lyme disease is the most common vector-borne illness. It is most common in the mid-Atlantic and coastal Northeast, with 12 of these states having 95% of reported cases. The main vector in North America is the black-legged tick, also known as the deer tick. About 1% of tick bites actually result in Lyme disease. Lyme disease occurs bimodally with respect to age, with highest occurrence in 5 to 9-year-olds at 8.6 infections per 100,000 children. Adults between 55 and 59 years of age have the next highest rate at 7.8 cases per 100,000 individuals. 20 to 24-year-olds are least likely to contract this disease with only 3 cases per 100,000 individuals. Lyme disease is spread through the bite of an ixodes, a hard-bodied tick infected with Borrelia. Ticks are a type of arachnid that goes through incomplete metamorphosis. This means that the younger stages of the arachnid's life look similar in appearance to the adult form and usually eat the same food. An ixodes tick goes through a 2-year-long life cycle with 4 developmental stages: egg, 6-legged larvae, 8-legged nymph, and adult. They begin as eggs in the spring of the first year and become larvae during the late summer. Larvae must have a blood meal to become nymphs and often feed on small animals, frequently white-footed mice. Research has proven robins to be competent hosts and some reptiles. Some lizards have a borreliocidal substance in their blood that eliminates Borrelia from feeding ticks. The ticks can acquire Borrelia during their larval blood meal. Once nymphs, they feed again during the spring or early summer of the second year and can transmit Borrelia to humans or large animals at this stage. The nymphs must feed for 24 to 28 hours to successfully transmit Borrelia. This is the time required for the bacteria to migrate from the tick midgut and travel to the salivary glands. The nymph becomes an adult sometimes between mid-October to early November and will feed again, often on deer. Deer are the preferred enzoic feeding host, and dogs, horses, people, and other mammals are simply accidental victims of a hungry tick. Deer are actually not competent hosts for B. burgdorferi, and as their role is to maintain ticks, not the Borrelia bacteria. Transmission to humans can occur during the nymph or adult stage. A tick cannot jump or fly. It finds its host by hanging onto a blade of grass or a shrub with its rear legs and reaching out with its front legs. When a possible host brushes against the tick will climb onto the host and crawl around until it finds a suitable spot to begin feeding. When ticks find a good location to begin feeding, it cuts open the skin and places its feeding tube into the wound. Some ticks may secrete a cement-like substance which ensures that the tick will stay on the host. Others have barbed feeding tubes to ensure that they will not come out easily. They also have anesthetic compounds which can prevent the host from feeling the tick feeding. After several days of feeding, the tick will drop off and prepare for its next life cycle stage.
Spirochetes have a plasma membrane surrounded by a peptidoglycan-containing cell wall encased in an outer lipid bilayer membrane. This type of membrane causes spirochetes to stain as gram-negative, although they are considered neither gram-negative nor positive. This outer membrane sheath is separated from the cell wall by the periplasmic space, which contains the periplasmic flagellae. The individual flagellae are attached to one end of the inner cell and extend toward the opposite end. The flagellae give the spirochete its wave-like shape and enable it to swim faster in highly viscous mediums than in low-viscosity media. This enables them to live in intestinal tracts, mucosal tissues, biofilms, aquatic sediments, etc. Because they are within the periplasmic space, they do not trigger an immune response from the host like external flagellae would, enabling the spirochete to successfully infect the host. Borrelia have a diameter of 0.2 to 0.3 micrometers and a 20 to 30 micrometer length. Because their narrowness compared to length is below the resolving power of light microscopes, they are usually viewed with dark field microscopy. At rest, they are flat wave-shaped with planar sinusoidal deformations. They swim by rotating counterclockwise in a corkscrew fashion, while waves propagate down the length of the spirochete. Their membrane contains several lipoproteins, which are selectively expressed to allow survival in ticks and once transmitted to another host. Borrelia can be cultivated in vitro, although only on Barber Stoner Kelly BSK medium. It does best in microaerobic environments at 32 degrees Celsius, but still takes 12 to 24 hours to grow. It can be grown from fluid from ticks and the cerebrospinal fluid, skin, and blood of Lyme disease patients. Borrelia burgdorferi have a linear chromosome at 21 plasmids that contain 40% of its total genome. Both the linear chromosome and the high number of plasmids are unusual among bacteria. While the chromosome contains genes found in other bacteria, the majority of the genes found in the plasmids are unique to Borrelia. The big burgdorferi genome has been completely sequenced and can help in identification. Borrelia practice stealth pathology for survival. This means that they not only infect, but also can do the following: suppress the host's immune system, metagenesis to gain antibiotic resistance, physical seclusion or the ability to choose poorly vascularized tissues in the host to colonize, secreting factors to adhere to and pierce host cell walls, and switching life stages, including changing to dormant stages in hostile environments. Borrelia life cycles. A life cycle is a diverse array of life forms which emerge in an ordered sequence. Several of these forms have been discovered for Borrelia. Aside from the well-known corkscrew form, there are cystic, granule, L forms, liberated periplasmic flagellae, and genetic mutants. The forms can sometimes be concurrent with one another, and often more than one method of microscopy or type of dye must be used to detect all forms present. There are three cystic forms of Borrelia. Inducible cysts occur as the Borrelia corkscrews curl up into a cyst within their own membrane. These cysts are considered inducible because they occur in response to unfavorable environments caused by acidic pH, antibiotics, lack of nutrition, and other causes. The corkscrew form can still be seen using dark field and electron microscopy. Inducible cysts are formed quickly, often in less than 1 minute, and can return to corkscrew form just as quickly should the environment change. The second cyst type is a bag of fluid, a cyst consisting either of a membrane and cellular fluid in the empty form, or containing some content, either filamentous or nucleoid. Both the empty and not empty test positive for DNA. The name comes from the visual appearance of emptiness. The third type is the age cyst, which is filled with dense granules that are released into the environment if the age cysts rupture. Age cysts cannot quickly return to corkscrew form. As corkscrew forms age, their DNA-containing regions begin to segment, resulting in an intermediate Morse code form. These segments, holding DNA or RNA, break apart and become more grounded in the environment, forming granules. Research has shown that some of the granules in the affected hippocampus cells of Alzheimer's patients may be granular Borrelia. This could explain the possibility of contracting Alzheimer's as a long-term effect of Lyme disease. L forms are forms that have lost their cell wall but are still viable as bacteria. L forms are thought to play a role in horizontal DNA transfer from Borrelia to other cells. Liberated periplasmic flagellae have broken from the parent form. They are tiny, regularly curled, and immotile. A common genetic mutation in Borrelia is to have no flagellae. This prevents the corkscrew form and causes the Borrelia to appear to be an immotile bacillus form, difficult to correctly identify as a spirochete. For many years, scientists and doctors expected to see spirochetes in their corkscrew forms only, causing them to miss many spirochetes in other stages of their life cycle. Being able to identify Borrelia in any stage of its life cycle helps in accurately diagnosing and further research of Lyme disease. Other forms of Borrelia may also help explain the mysterious long-term effects of Lyme disease.
Symptoms. When an infected tick bites, the victim experiences itching and redness around the site of the bite. The rash, known as erythema migrans, is said to often look like a red bullseye. This is a skin lesion that occurs at the location of the tick bite in 60 to 80% of the patients, usually 7 to 14 days after the infection, although it can range from 1 to 30 days. It begins as a red papule, which expands into a round lesion with red borders and a central clearing. Since the spirochetes can spread, patients can have erythema migrans in multiple locations. An erythema migrans lesion with 5 cm diameter appearing within 3 to 30 days of tick exposure is the only symptom sufficient for the diagnosis of Lyme disease without further testing. Early stages of the disease have flu-like symptoms. These include stiff neck, chills, fever, swollen lymph nodes, headaches, fatigue, muscle aches, joint pain, dizziness, and shortness of breath, and lymph node enlargements. Skin rash develops just before the victim develops arthritis symptoms. Left untreated, the disease will cause heart, brain, and nerve problems. The nerve issues are especially prominent in the knees. Other serious issues that result are arthritis, neurological symptoms, heart problems, eye inflammation, severe fatigue, and loss of muscle tone. Nervous system abnormalities such as numbness, pain, partial paralysis of facial muscles, and meningitis can occur. Of course, severity can vary from person to person, but these are all common symptoms and issues that arise from the disease. It is important to note that not all of these symptoms occur in every case.
Diagnosis. Other symptoms are often and frequently confused with influenza, infectious mononucleosis, and rheumatoid arthritis. A doctor can't always diagnose a patient by testing their blood for antibodies to Lyme bacteria because early stages of the disease may not show up in results. Blood testing, however, can be helpful in later stages of the disease. When the antibodies are present in the body, this is an indicator that the body is trying to attack and fight off the bacteria. These antibodies are detected by using a laboratory method known as enzyme-linked immunosorbent assay, or ELISA. The presence of antibodies can be a false indicator of the disease, though. This is due to the ability of antibodies being able to persist for years after the disease is cured. These false positive tests in patients lead to nonspecific findings and confusion. Overall, Lyme blood testing is really more helpful in patients with confirmed Lyme disease and monitoring the progress of treatment. Right now, the most reliable confirmatory test is the Western blot assay antibody test. Scientists are working to develop more accurate tests, using polymerase chain reaction, or PCR, to amplify DNA found in blood, skin, cerebrospinal, and synovial fluid, and checking that genome against the known B. burgdorferi genome is becoming a more common practice today, but is still not considered standard.
Long-term effects. Patients can have irreversible damage to tissues, leading to incomplete recovery. One common example is continuing facial weakness after facial nerve palsy during Lyme disease. Patients can also experience continuing fatigue, headache, myalgia, arthralgia, sleep disorders, and memory and concentration difficulties after being cured of Lyme disease. This is known as post-Lyme disease syndrome.
Research of causes of long-term effects. One common long-term effect of Lyme disease is arthritis, along with other musculoskeletal issues. About 25% of patients treated with antibiotics early in Lyme disease experience prolonged arthritis after being cured of the disease. Patients who were given antibiotics late in Lyme disease frequently already have arthritis that turns into persistent joint pain after being cured. This pain is untreatable by antibiotics. These long-term effects are mostly unexplained. However, research is being conducted to find an explanation. One possibility published in research this year is that B. burgdorferi antigens and inflammatory debris may remain near cartilage and articular surfaces. The picture shows a segment of mouse ear cartilage from the study. The first square shows the spirochete form marked with a fluorescent protein inserted into a gene that deals with viability. The second square is after treatment with antibiotics. The spirochete forms are missing, but there are still fluorescent clumps showing material left behind in the cartilage. The last square is a control from an uninfected mouse. The study concluded that antibiotics would completely remove infectious spirochete forms from many strains of laboratory mice, but that DNA, antigens, and other materials were left behind. However, the antibiotic-treated cured mice could not infect other mice through xenodiagnosis with ticks, tissue transplants to healthy mice, or give rise to spirochetes in culture, clearly demonstrating that the mice were still not infected, although there was remaining bacterial material in their cartilage and entheses. This leftover material could explain the prolonged and antibiotic-resistant arthritis and other long-term human symptoms related to joints and inflammation.
Prevention and treatment. In order to protect yourself when outdoors, use insect repellent that contains an EPA-registered active ingredient. You should also wear light-colored socks and pants to help spot any ticks, and you should tuck your pant legs into socks or shoes to minimize skin exposure. It is also advised that you spray your clothes as well. If at all possible, you should avoid heavily wooded and highly grassy areas. Brush leaves away from your house and keep your lawn well maintained. Trim any low-lying bushes to let in as much sunlight as possible. This will all help prevent your yard and home from becoming home to mammals that act as hosts to ticks. You should get into the habit of examining yourself and pets after they have been outdoors. If you do find a tick, use a pair of tweezers for removal. Grasp the tick's head as close to the skin as you can without crushing it. Pull it directly out and dispose of the tick in a manner that it will not continue to live and wander around. Never use petroleum jelly or hot objects to remove ticks because these methods can increase your chance of a host tick injecting you with the dangerous bacteria. If you have any concerns or experience with any of the previous listed symptoms, you should visit a doctor. In early stages, most or almost all cases of Lyme disease can be effectively treated with prescribed oral antibiotics, most commonly doxycycline and amoxicillin. Children and pregnant women must be treated with amoxicillin. The antibiotic is typically given for 14 to 28 days. If the illness is not caught early on and therefore permitted to progress to later stages, the disease may require IV drugs such as cefalozone to relieve the patient of nervous system and cardiac symptoms. For relief of symptoms, a pain-relieving medication is usually prescribed. Swollen joints are reduced by a doctor removing fluid from them. This is an arthrocentric procedure where fluid is removed from a joint using a needle and a syringe in sterile conditions. With antibiotics, arthritis rarely persists. After eradication of Lyme disease, research has said that any persistent joint inflammation is explained as an ongoing autoimmune response causing inflammation of the initially stimulated joint. Oral medications are used to reduce this inflammation and improve overall function. At this time, no vaccine is available. There was a vaccine, but it was removed from the market due to lack of demand. This concludes our presentation on Lyme disease. We hope you enjoyed the show.